Hi, good afternoon, everyone, and thank you for joining us today. I'm Janelle, Business Development Manager at One Heart Clinic, and we are delighted to host this 45-minute CPD section on chest pain in primary care. Today's session is designed to provide a structured, practical approach to chest pain assessment, helping you feel confidence in your decision making around investigation, referral, and reassurance. We're joined by two excellent consultant cardiologists today, and we will finish with an Q&A at the end. Please feel free to drop your questions into the Q&A box as we go along. Our speakers will try to address them during the section. Now, I'm delighted to introduce our first speaker, Dr. Richard Jabbour. Dr. Jabbour is a consultant interventional cardiologist at One Heart Clinic London site and University Hospital Southampton NHS Foundation Trust, one of the UK's leading cardiovascular centres. He has extensive expertise in coronary and structural heart interventions, including TAVI. He trained at several leading London institutions and is also an honorary senior clinical lecturer at the National Heart and Lung Institute, Imperial College London. Dr. Jabbour, thank you for joining us today. I will hand over to you now.
Thank you. Thank you very much. So I'll just get my talk up. Can you see my slides?
Yes, we can see your screen now.
Fantastic. Okay, I'll just let me just get the question and answer box. So yeah, thank you so much for the introduction. So I'm just going to talk, in the first part, mainly about the kind of history and preliminary investigations, and then Dr. Joshi will go on to sort of the referral. Chest pain in primary care is a challenge, and differentiating from non-cardiac chest pain, is important, and it accounts for around 1 to 3% of all GP referrals and around 5% of A&E visits. Whilst the vast majority are non-cardiac and probably musculoskeletal, it is important not to miss a cardiac cause, which can account for up to 15 to 20% of cases. This is because early ACS recognition saves myocardium, and if it's missed, it is a potential cause of litigation. So the mission is to rapidly identify life-threatening causes while avoiding unnecessary ED referrals for non-cardiac, musculoskeletal or GI issues, for example. It is challenging though, because not all chest pain is equal. So for example, retrosternal chest pain could be myocardial ischemic pain, but it might be something else like esophageal pain. Could be something related to the respiratory system like a PE or even mediastinal lymphadenopathy. Chest pain can be in various different locations. For example, if it's in the shoulder, again, this could even be myocardial ischemic pain. So it can be a real challenge to diagnose cardiac pain from non-cardiac pain. And even as cardiologists, when we get referred someone with angina or classical angina, we often think of it as being related to the epicardial system. So, for example, one of the major blood vessels, such as the left anterior descending artery, having a severe stenosis, that could be treated and with stenting if needed. But it actually now is becoming apparent that a lot of angina is related to the microvascular compartment, and we are using, up-to-date tests to try and diagnose microvascular angina and treat this accordingly. And notably, if it's microvascular angina, this is not amenable to treating with stents, which we can only treat in the major blood vessels. So it is a challenging kind of a field. Helpfully, there are some characteristics in the history that do increase your pretest probability of having, angina or significant coronary artery disease. This is a kind of nice review from 2017 in Heart that really goes into the characteristics of chest pain. And there are kind of three main kind of characteristics of the chest pain that increase your pretest probability of having coronary artery disease. So if, for example, the pain is central in location, lasting between 5 to 15 minutes, that's one. An important one as well is if it's provoked by exertion or emotional stress. So people often discount stress as a kind of provocating factor in angina, but actually angina is really provoked by emotional stress. And another characteristic if is relieved promptly by rest or GTN or nitrates. So if you have all three of those, that is typical angina. If you have two out of the three, that's atypical angina, or less than and equal to one, that is non-anginal. So that is really what you need to get in the history. Then you can go on to do your kind of physical examination, your risk factors, and your routine investigations. Now, differentiating between typical, atypical, and non-anginal is important because, as I mentioned before, there is a pre-test probability depending on the characteristic of the chest pain. So if it's typical, so central, provoked by exertion, relieved by rest, and you're a male, you have a higher likelihood than a female, and there is a very strong correlation with age. So for example, a male age 30 to 39, there is a 3% chance you're going to have significant coronary disease. But if you're 70 and above, a male with typical symptoms, it is over 50% likelihood. Women, interestingly, obviously there is a very strong correlationship with age, but they tend to actually present with more atypical symptoms, and it is underdiagnosed in the population. So there really needs to be an awareness when taking histories from female patients, because they are often underdiagnosed and even undertreated once they get to the ER and undergo cardiac investigations. Nevertheless, for example, if the pain is typical and the patient's over 70 and a female, there is still a very high likelihood, so 27% chance of significant coronary artery disease. This goes down gradually depending on kind of symptoms, but notably, if you look at the box on the right, if it's kind of shortness of breath and typical symptoms, it can be up to 30%. So it is important to just think of pre-test probability when assessing patients with chest pains. There are some specific key points in the history. So cardiac pain related to ACS or angina is typically like a pressure squeezing band-like pain. As mentioned before, it's kind of minutes as opposed to seconds or even days. It's typically non-tender and diffuse retrosternal location, as opposed to sort of being able to localize it and being tender to touch, which is typically associated with non-cardiac causes. As I mentioned, it's usually worse on exertion, relieved by rest or GTN. And the classic radiation is to one arm, sort of the left arm or even both arms and the joint and the jaw. If there are typical associated autonomic symptoms such as sweating, again, that increases the pretest probability of this being ACS or angina. For those of you that like scores, when assessing patients with chest pain in primary care, there is this Marburg heart score, which is quite interesting and was validated in primary care in Germany. And it consists of essentially 5 kind of variables. And a lot of it's taken from the pre-test table that I showed you before. So if you're female greater than 65 or male greater than 55, you get 1 score. If you have risk factors such as known coronary artery disease, cerebral vascular disease, or peripheral vascular disease, that's another point. Pain on exertion, that's another point. If it's reproducible with palpation, then you don't get a point. And interestingly, if the patient assumes that the pain is cardiac, you get a point. And what this is useful for is a kind of rule out thing rather than a rule in. So if, for example, your score is less than or equal to 2, there is a negative predictive value of over 97% for it being non sort of unstable or ACS pain. So then you can relax, you can do your investigations and do a non-urgent referral if required. If there is a kind of high risk score, the positive predictive value is slightly lower. So but nevertheless, urgent referral or inpatient admission may be required. So that is quite a useful heart score, and it has been validated even in emergency departments now, whether to kind of risk stratify them into urgent beds or not. So it is an area of research, and there is some interesting data coming out regarding this score. So obviously, when you're assessing a patient, there needs to be a systematic approach to risk stratification and diagnosis. So obviously, if anyone is hemodynamically unstable, or they're in pulmonary edema with a respiratory rate of 30, they have pain radiating to the back or both arms, or signs and symptoms consistent with a PE, these are your kind of classical red flags where you need to refer emergency to the emergency room. So obviously, observations are of critical importance, and basic clinical signs such as pulmonary edema, again, very, very important. Now, the NICE guidelines went into kind of investigating chest pain, again, are very, very important, and they offer some specific red flags related to chest pain. So if the pain is ongoing greater than 20 minutes with new ECG changes, or syncope or pulmonary edema, or if they have a background history of ischemic heart disease with new symptoms, these really do need, emergency referral. They go on to state, and obviously it's important to appreciate that the clinical context overrides the ECG. So if the patient is, for example, presenting with a classical history of pain that was on exertion after 100 meters, and now it's gradually increased, and now they're getting pain at rest, and the ECG is normal, that is unstable angina, and they need to be referred. So the clinical context always overrides the ECG. In fact, I've seen patients and taken them to the cath lab with a normal ECG because the history is so consistent with an ACS, and they will have a blocked left circumflex. So that is a classic kind of, the left circumflex doesn't always present with ECG changes. So the clinical context is always important. Now, the NICE guidelines also stratify chest pain into the timing of chest pain. So if the patient's pain was greater than 72 hours and they have no complications, they say that you can consider diagnosing an ACS in primary care. When they mean complications is such as, pulmonary edema, for example. The reason I think that they do the cutoff of 72 hours is because the prognostic benefit of early intervention with stenting is diminished the longer the time goes on. So after 72 hours, if they've been pain-free for a long time, we often manage these patients medically. So they suggest doing an ECG. And for example, there are specific ECGs that may indicate ischemia, such as your Q waves, left bundle branch block, or persistent ST or T wave abnormalities. Again, a normal ECG does not confirm or exclude the diagnosis of ACS. They then go on to say that actually, if they've been pain-free for 72 hours and, it sounds cardiac, you could do a cardiac troponin, either troponin I or T, to differentiate from unstable angina from MI. So that's something to think about. So troponin is a kind of protein in all muscles. So it's present in musculoskeletal muscle and cardiac muscle. But the troponin that we use to test for is specific to the cardiac isoform of troponin. And over time, the assays have become more and more sensitive. So when I was training, patients would get admitted to A&E with chest pain, and you'd have to do another troponin at 12 hours. That's because the troponin isoform essentially was only really detected after 8 hours. But with the advent of the high sensitivity troponins, you can do rapid rule-out testing for ACS between 1 to 3 hours. So, over time, the detection of troponin has become more and more sensitive. But you do need to become, you do need to be careful when ordering these tests, because there are, as the kind of isoform and detection has become more sensitive, the false positive rate has gone up. For example, troponin elevations could be due to direct cardiac damage from drugs such as chemotherapy causing cardiotoxicity, myocardial strain, such as a patient with high blood pressure, very high blood pressure, that can raise your troponin, myocardial ischemia secondary to even hypotension or anemia, as opposed to the type 1 plaque rupture that we are obviously so concerned about when assessing patients with chest pain. It can also be due to things like CKD and end-stage renal failure. So we do really get a lot of false positives. So in terms of kind of NHS guidelines, this is from the York kind of ICB. It kind of nicely follows nice guidelines and essentially says, do not request the troponins in primary care or community if the patient has a suspected acute coronary syndrome. That's a direct kind of emergency referral. If it's within 72 hours, again, direct referral. However, if it's after 72 hours, patient is pain-free with no complications, you may use a troponin. And depending on the cutoff level, it could risk stratify how you manage this patient. So it's just something to think about in primary care, but it can obviously, cause a lot of problems if you do a troponin and then they go home and then you get the test and it's positive, and it just can cause a lot of issues. So if in doubt, I would always say clinical context, refer urgently. So it's all, as I mentioned before, it is a potential cause of litigation. So we need to be very careful with documentation. So if you are sort of not going to refer, you need to sort of document and safety net. So clear 999 advice if there's a recurrence. Document the ECG findings. There's nothing, no SD changes. Record the reasoning for decision, and if necessary, arrange a follow-up. I think I'll skip over this briefly because I think Dr. Joshi will mention, but the NICE guidelines kind of stratify into urgent same-day assessment, 2-week referral, or routinely. And essentially, if they've got suspected ACS, it's a kind of an urgent same-day assessment if they're pain-free within the last 12 hours or within the last 12 to 72 hours and no complications. And it's a routine kind of rapid access referral if they have stable angina. So the key take-home messages, it's important to rule out the life-threatening causes first. So observations, characteristics in the history. A normal ECG does not equal ACS. Have a low threshold for referral, and I'd urge you to follow the NICE guidelines consistently, as they really do set out very objective measures. So in summary, chest pain can be a result of many different pathologies, and it's critically important to take that thorough history and risk stratify to guide your management. If in doubt, discuss with cardiology and refer to ED for assessment. Thank you very much.
Thank you very much, Dr. Jabbour, for those valuable insights. And now it's my pleasure to introduce our second speaker, Dr. Nikhil Joshi. Dr. Joshi is a consultant interventional cardiologist at our new opening One Heart Clinic Bristol site and the Bristol Heart Institute, and a senior lecturer at the University of Bristol. He is recognized as one of the UK's highest volume TAVI operators and has extensive experience in complex coronary angioplasty and structural heart interventions. He completed advanced cardiology training in Edinburgh, including a clinical PhD, and later undertook a prestigious BCICS fellowship in Canada, specializing in advanced interventional techniques. Dr. Joshi, we are delighted to have you with us. Over to you now.
Thank you, Janet. Thank you, Richard, for a fantastic talk. Hard act to follow in some ways, so I'll try my best here. So just trying to work out the screen here, first of all. So let me see if this works. Can you see my screen or?
No.
Richard, could you just close the sharing
Yeah, of
screen?
course.
Yeah.
Sorry. Yeah, sorry. Thank you.
Try again, Dr. Joshi.
Yeah. So sorry for this. Just bear with me again.
Yeah.
Yes, we can see your screen.
Let me see if I can. Can you see it on the presenter view, or I think it's the
It's the presenter view, yeah.
Just 1 second. I'll just. Yeah, is that better? Can you see it now or full screen?
Yes, we can see the screen and yeah.
Perfect. Yeah.
Yeah. Okay. Perfect. So I'm just going to follow on from Richard's talk. I think this is more sort of specific about when to refer these patients for assessment for secondary care pathways in some ways. So I'm Nick Joshi. I'm one of the consultants here in Bristol. Um, in terms of the main topics I want to cover, I want to talk a little bit about the urgent versus routine referral criteria. So, uh, you know, uh, in the primary care, your objective obviously is efficient risk assessment. The question here is how do we take it forward to the next level in some ways. The second point I want to cover is the safety netting and managing the strategies, which we sort of briefly touched on the previous talk. Then what are the tips of effective communication in the referral, which are quite important in terms of pointers for us so that we can expedite these patients and sort of manage them effectively. And then I'll talk about a few practical scenarios here with regards to how we sort of manage these patients and what are the common presentations for these patients. We all know the risk factor profile of these patients. We know the underlying pathophysiology in terms of what drives the coronary disease. So we know that the causes of atherosclerosis are complex, multifactorial, and include things like elevated cholesterol levels, elevated blood pressure, smoking, diabetes, obesity, and obviously family history. Now it's fascinating. The whole sort of area of high cholesterol has now opened up, and you will see increasingly newer sort of risk assessment measures such as lipoprotein layer, for example, which are come into the market for assessment, and you'll see it more and more in terms of the primary prevention. So coming back to the primary care reality, in some ways you can argue it's a diagnostic trap, because really what you have is a 10-minute presentation where the probability of finding something very important is relatively low. So uh, so the sa- the if you see say 10 patients with chest pain, the likelihood of finding statistically important coronary disease is low as compared to us, for example, who will come where patients will come in a more straightforward way, and we have access to all the investigations. So in a 10-minute window, you need to have high clinical there's high clinical anxiety, and obviously there is severe consequences of missing important coronary disease. So what is difficult is balancing the low risk probability against the high likelihood of litigation of missing important disease, and that kind of causes a lot of friction and anxiety in some ways. And our primary objective in this case should be to systematically rule out important conditions which need urgent treatment. That is to say, rule out patients with acute coronary syndrome before offering reassurance. So as Richard touched on, things like, for example, ECG don't necessarily rule out, acute coronary syndrome in this setting, and it is important to transfer these patients appropriately. Now, if you understand the underlying pathophysiology of these patients, what you see is on one end of the spectrum, you have patients with stable atherosclerotic plaque, where the fibrous cap, which is sort of the structure separating the plaque from the lumen, is intact. And what that means is it creates the situation of demand ischemia. On the contrary, the pathophysiology of unstable plaque, which is the underlying substrate for acute coronary syndrome, is entirely different in that it is primarily driven by complex processes such as, say, plaque rupture and plaque erosion. And that is fundamental to the further management and understanding of the clinical scenario. So whenever you see patients who complain of acute onset chest pain, you know, um, which has come on suddenly, lasted for more than 20 minutes. You have to suspect plaque rupture, and the best way to manage these is actually transferring them immediately to the ED, calling 999. Then the second category of the patients are patients with what we would call as new onset chest pain. Now, this particular sort of entity in some ways is different to your classic stable angina, because obviously stable angina means that the lesion is stable. The fact that there has been a material change in the symptoms means that they need relatively urgent assessment. And for this, we have well-established pathway with the rapid access chest pain clinic within the NHS, and of course, in the private setting, you can mimic that, where patients can wait for 1 to 2 weeks before they are accurately assessed by a clinician who has access to further investigation from a cardiac perspective. The third category of patients are those who have, known ischemic heart disease, so things like previous stents or bypass, but require optimization. So, the first category in some ways is the most important to recognize because they need very urgent care and calling of ambulance services or emergency services in some ways. The second category is something you don't want to miss. The third category is something you can optimize the medications. You can have a cup of tea and then decide what is best for the patients in some ways. So it's important to get this sort of principle, clear in your mind once you have decided the patient is describing cardiac sounding chest pain. Um, so this is an example of a patient who obviously had acute coronary syndrome. He has bystander disease, and what you typically see is an occluded vessel here. For example, this could be a patient who has got clear cardiac elevation MI, and this is treated by stent. So once these patients come into the hospital, their pathway is fairly streamlined and includes a host of things, including aspirin, clopidogrel, and going to the lab in at some point within their patient journey. Um, Now, building on this, just touching a little bit on the NICE guidelines for the new onset chest pain, which obviously Richard has touched on a little bit. The shortcut to the diagnostic sort of criteria involves three important points. One is a patient complaining of exertional chest pain. Second is the pain typical in that it is described as being pressure or heaviness in the chest and it's not sharp in nature. And finally, does it stop with rest? And if all three symptoms are typical, are positive, you'd call it as typical angina, and you'll refer the patients for urgent assessment with cardiology. Um, Now, once we establish that the patient has described typical cardiac sounding chest pain, the next important topic is that of the safety netting and managing various strategies that are defensible in the primary care. So one of the important principles here is, you need to be quite exact in terms of the description or the advice given to the patient. So um, the general advice would be that if the patient complains of pain that occurs at rest for more than 15 minutes, it's best to call 999. So by completely documenting this sort of sentence, what you're doing is you're covering yourself in entirety by saying, look, I have given a time directed advice that it's 15 minutes. And if it is beyond that, you're calling the 999. Of course, in the interim period, you're trying to establish a treatment. You can't wait for the secondary care to establish patients on these treatments. So you're going to start them on aspirin, on high dose statins, on GTN and beta blockers as an interim measure till they're seen by the cardiology clinic. In terms of tips for effective communication in the referral, the precision in the referral communication is quite important. And, I like to have three important sort of parameters within that. So the first is, what is the functional limitation for the patient? In short, what we call as the Canadian, class anginal symptoms. So CCS class 1, CCS class 2, or 3. So this is kind of well established, as you all know, with regards to how you describe angina in some ways, but equally, if you just want to keep it short, if you say, look, the patient can walk, say, 2 flights of stairs, and after which he has a typical chest pain, that is not a unreasonable sort of description, because it still tells me, what kind of functional limitations they're having and what impact they have on the quality of life. Second, objective marker is the precise symptom related to exercise. So is it actually chest pain, is it jaw pain, or in fact, is it breathlessness? Because a proportion of these patients do actually present with just dyspnea as their primary symptom. Finally, the risk factor profile, the sort of detailed chart which Richard alluded to, it gives us a good idea about a patient who has got, say, multiple risk factor profile, who has likelihood of coronary disease. It is important to distinguish that, of course, you can have patients who have typical angina without coronary disease, but equally you have patients who have atypical angina with multiple risk factors. So, it's almost like, two sort of subsets which overlap when there are symptoms. So you may have patients with coronary disease, in fact, without any symptoms for that matter. So it's important to understand, that the vascular burden can drive anginal symptoms, but equally you can get anginal symptoms independent of the risk factor profile. And finally, the resting ECG is very important. Although a normal ECG doesn't exclude, presence or absence of coronary disease or ischemia per se, it's important to understand that it's an important piece of information for completion in some ways. Now, coming back to the 2016 guidelines, which has been touched on, the angina can be typical or atypical. Um, uh, you know, it is generally recommended that exercise tolerance test shouldn't be undertaken in these patients as a first-line investigation, especially for the new onset chest pain. So what you will see is when the patients come to us, often they have CT coronary angiogram as the first-line investigation. Exercise tolerance we don't use nowadays for diagnosing angina, but it does provide very important prognostic information, especially for patients who are known to have coronary disease. Um, Non-invasive functional tests, such as dobutamine stress echo or myocardial perfusion scan, or in fact, you'll see myocardial perfusion scan and cardiac MRI being increasingly used when there is uncertainty, about the lesions in the CTCA, for example, or even as a first-line investigation for that matter, in patients who can't have CTCA. Of course, initial management of angina should include optimal anti-anginal treatment and risk factor profile management. This is on the basis of several studies that have been undertaken in this area. And finally, invasive coronary angiography and myocardial revascularization should be considered only for patients who have significant anginal symptoms despite anti-anginal treatment. I'll just go through a few diagnostic modalities that are quite common, and you'll see in your practice. Of course, ECG is very common. Almost everyone who's referred to cardiology has ECG. Echocardiogram is important in these patients, and if you do have access to echocardiogram, it's not unreasonable to do this when you're referring these patients. So, to assess the structural integrity, valvular heart function, as well as ventricular motion in these patients. As I said, CT coronary angiogram is the first line gold standard test for anatomy currently, although it has got varying degree of sensitivity and specificity. But the important element of this it's very good for normal or near normal coronary arteries. So to exclude coronary disease, it's a very important test in my view. So with this background, let's go through a few scenarios which may be of relevance. So first scenario is a 48-year-old plumber attends the practice with chest pain for 7 days. Describes sudden onset chest pain relating to the left arm while watching TV. So pain at rest. Pain has lasted for about 30 minutes in total. And subsequently, he complains of exertional chest pain that comes on in a very predictable fashion after exercise. He has got risk factor profile that includes a strong family history and being a smoker of about 20 pack years. So what are the next management? What he's describing really, you have undertaken an ECG, by the way, in the practice, and essentially it has shown a normal ECG with a heart rate of about 70 beats per minute. So what he's typically describing is post-MI angina, because he classically had chest pain that lasted for about 30 minutes while watching TV, and then he's got exertional chest pain whenever he's walking. So there are two ways to manage this. In some ways, if you have, you can, as Richard said, it's about 72 hours after the initial presentation, and there is a bit of ambiguity about how you manage these patients. For sure, these patients should be on aspirin, GTN spray, beta blockers, atorvastatin, and other medications. But a strong case can be made that this patient should go to ED for further assessment, because I think that's in the current NHS system. I think that's probably the sure shot way for him to get an angiogram, because you don't know how long it is going to take him. Equally, for example, if this patient turns up in our rapid access assessment clinic, I'm pretty sure he will be, probably admitted maybe the trop will be high and all those kind of things. So the important point here to make is that the resting normal ECG does not exclude a recent myocardial infarction, especially in the circumflex territory. The second scenario I have is a patient who is 72 years of age, seen at your practice, complains of exertional chest tightness for last 2 weeks. The pain is lasting for about 5 minutes or so, after which it goes away after rest. His past medical history is important, includes previous myocardial infarction about 8 years back. He had primary PCI and sent to his medial AD. He's in good health. His medications, he's on secondary prevention, includes aspirin, statin, ramipril, bisoprolol. And his heart rate is about 70 beats per minute. What is the optimal management in these patients? Um, so first thing to say is that the heart rate is quite high, which means we need to up titrate his beta blockers. He is someone who has, stable angina in some ways, but equally he has previous stents. Now, the only other important feature here is that the pain has come on in the last 2 weeks, which might mean there is sudden change in his plaque anatomy or some of the factors that is driving it. But it is not unreasonable that we refer him for cardiology. If you're really concerned, you can surely refer him for the rapid access chest pain clinic. A functional testing would be appropriate here. For example, a stress echo or a stress MRI. But equally, a lot of cardiologists would proceed with the invasive coronary angiography, given the step change in the symptom and established coronary disease. From a primary care perspective, it's important to up-titrate his beta blockers. It's important to note that CT coronary angiogram is not appropriate here because of the stent artifact that you often see, and it makes it very difficult to analyze the underlying plaque beneath or close to a stent. Third patient is someone who had a previous coronary artery bypass grafting. He's now presenting with exertional angina, typical symptoms, coming on less frequently on a fortnightly basis. Medications, again, appropriate secondary management. The difference here, obviously, is that the heart rate is 52 beats per minute. Blood pressure is well controlled. So in this situation, because his heart rate is well controlled, it's not appropriate to increase the beta blocker, or it would be catastrophic to add a calcium channel blocker in some ways, because you can't give calcium channel blockers rate limiting with the beta blocker. So in this situation, long-acting nitro or amlodipine, such as amlodipine or ranolazine, is more appropriate treatment. Just sort of touching very shortly on the first and second line, anti-anginal treatments. So obviously calcium channel blockers, beta blockers are the first line treatments, first and second line treatments, and then medications such as nitrates or ivabradine or even ranolazine, for example, which are licensed for use in this or initiation in secondary care, are more sort of second or third line treatment nowadays. I do prefer ranolazine increasingly because it's such a good medication without any significant hemodynamic compromise. So you'd see a lot of patients being started on ranolazine increasingly. So to conclude, patients with exertional symptoms of angina should be considered as cardiac chest pain unless proven otherwise. Normally, CG does not exclude coronary artery disease. It's important to document explicitly and safety netting. And I'm happy to take any questions on this. Thank you.
Yes. Thank you very much for Dr. Jabbour and Dr. Joshi for sharing your expertise and practical guidance. Now we do have quite a lot of questions in the Q&A box. Could Dr. Joshi and Dr. Jabbour just open the Q&A box and we want to
I've actually answered the questions as we get along. I think
we
there's one
still have one open.
Yeah, so this one maybe is to you, Nikhil. Why amlodipine? They've just said that.
Sorry, I'm just trying
I guess
to find
that is that as for scenario 3.
So just trying to see, is it relating to this one, is it?
Yeah.
Yes.
Yeah. I think, amlodipine we can consider as a first line anti-anginal, second line anti-anginal, I suppose, after beta blockers or rate limiting medications. It's a good effective medication, for vasodilation. And although its primary use is still in blood pressure management. And in this scenario, it may be a little bit tricky with a blood pressure of 124. It's a very good medication, which is quite well tolerated, as we all know. So that's the reason of using amlodipine. So my usual practice, having said that, in reality, we do skip a lot of these things, because when patients do come to us, a lot of them are on a beta blocker, on amlodipine, and often the only medication a cardiologist often adds is ranolazine in some ways. So, to answer the question, I think amlodipine is a good medication, good anti-anginal.
Yeah, and as you said, it's a first line in the guidelines.
Mm.
There's another one that you might want to answer as well from Dr. Hartman. What do you think of troponin T point of care tests?
Yeah, I think that's interesting and sort of slightly controversial thing now, isn't it? It is a
Yeah.
difficult one, and I think the question is, what do you do with the results? And that's what it comes down to me. I think, if the result is negative, I think for me the main thing here is the history. And you have patients who have trop negative, who have multiple risk factors, but the story is so classical that you want to actually send them for an urgent assessment. But equally, if the trop is positive, it just confirms what you're thinking in some ways, because the classic term of unstable angina, we used to have a situation where ACS was divided into sort of unstable angina and non-STEMIs. The reality is that the troponins are so sensitive that most patients either have non-STEMI or stable angina nowadays. That's the reality of it. So I don't have any strong views about it. If people are comfortable using it, they should use it. But I think you should be comfortable then, taking it forward in some ways, whether you send them to A&E or manage them sort of locally if they're negative and things of that sort.
Yeah, no, I agree completely with that, and I'd say they can be useful. But it's kind of you need to be careful because there are a lot of false positives, and it may introduce a lot of extra work, and the clinical kind of suspicion really only always trumps the troponin. And obviously in the NICE guidelines they don't even recommend you to do it unless the pain is after 72 hours. So it's not hasn't made its way into the guidelines yet. I can see some positives, but I can see also some negatives, especially with the false positives.
Cool. Thank you, both of you. Dr. Hartman, you are able to speak if you have any questions.
I think you put a couple of questions in the chat.
Yeah, I think we finished all the questions now. And thank you again for Dr. Jabbour and Dr. Joshi for joining us today. And thank you to all of you for taking the time joining us today. A follow-up email will be sent to you shortly with the recording. And if you have any additional questions you may have, please feel free to contact us. We hope you found the whole section useful and practical for your clinical practice, and we look forward to seeing you at our future sections. Enjoy the rest of your day. Thank you, everyone. Thanks.
Thank you.
Bye.
Thank you.
Thank you.
Thank you.